Professor of Department of Pathology at Mahatma Gandhi Medical College and Research Institute, Pondicherry. Sir had worked as a former professor and head at Department of Pathology, Jeetmal Medical College, Pondicherry. Sir is expertise in the hematopathology. Sir had done more than 239 publications. Chairperson for today's seminar is Dr. Mukul Agrawal, sir. Sir is working as an associate professor of clinical hematology at Department of Hematology, All India Medical Sciences, New Delhi. Sir is the associate editor for the journal IJHBT. Sir is also working as a section editor in hematology of Indian Pediatrics. Sir is a hematology expert working with the various institutes. Today's participants, please introduce yourself. Dr. Sheetal.
Good evening, everyone. Myself, Dr. Sheetal Uttal. I'm PG third year resident in TMH, Mumbai, from Maharashtra.
Dr. Sakshi. Dr. Viral.
Good evening, everyone. I am Dr. Viral Susad, third year resident from NHL MNC, Ahmedabad.
I think Dr. Shalini is not there.
Not there.
Shalini is not there.
Okay. Dr. Urvi is also not there.
Not there. Pritam also not there. Dr. Priya.
Dr. Priya.
Good evening, everyone. My name is Dr. Priya Joshi, second year PG resident from Indian Medical College, Talegaon, Bihar.
Dr. Saurabh.
Good evening, everyone. I'm PG second year resident from AIMS Guwahati.
Thank you, students. Moderator for the today's seminar are Dr. Geeta Vidyadharan. Ma'am is working as a senior consultant pathologist at Cochin, Kerala, and myself, Dr. Urvi Parikh, working as an assistant professor at BJMC Ahmedabad. Students, if you find low connection, interruption, low sound, please leave and rejoin with the same link. Answer the poll questions in the chat box and do not send requests for the annotation. Here are some disclaimers. Some more disclaimers. The upcoming talk, the next talk, we are going to start the CNS tumors. The first seminar on brain tumor is on embryonic tumor by Dr. Ayushi Sahai ma'am, and next is the adult type brain tumors by Silpa Rao ma'am on 20th March. Let's start, sir. Over to you, Devdatta Basu, sir.
Okay, Mukul be saying something, or shall I start straight? So just from my side first. Yeah, please.
Okay, sir.
So good evening, friends. As a chairperson for this session, I'll be chairing this and providing some clinical inputs to the talk. We'll be discussing on these two things. So, what all clinical input should be provided when the patient comes to us? Do it on a slideshow, please. It's not on slideshow yet, sir? No. Is it now?
Not yet.
Not really.
Not yet.
Full screen. Make it full screen.
Yeah. Sir, click on slideshow.
It's already clicked.
No, sorry, it's not.
Is it on slideshow now?
Probably you have to save.
I think it's okay. It's okay, Mukul. I think we'll manage it. Go on to the next slide. Okay, just a second. What we do is.
Yes.
Yeah. Okay. Sure. So when the patient comes to it and we are deciding on some hematological problem, what all input should we have and should provide to our pathology colleague? Starting with a small clinical history. What did the patient present with? The symptoms of the patient, the duration, if any family history, and this is important. We should provide any history of any recent transfusion for the patient. Then relevant examinations, especially pertaining to general physical examination findings, any organomegaly, liver spleen palpable or not, any special lymphadenopathy we are looking for or not. And lastly, and this is important, what is your working diagnosis? So let it not be just just don't write anemia or just like the low platelets. Whatever your working diagnosis on the clinical inputs, just provide that on your forms. What do we expect? We expect a rapid report, preferably within hours. This is important because this is something which is going to guide us into further investigation. So, as we discussed with our resident and informed them also, so a peripheral smear is the first step of the workup in a hematology clinic. So, this guides us into investigation for anemia workup, for any platelet abnormalities, for leukocytosis, leukopenia, whether you're dealing with hemolytic anemia, ITP, leukemias, TTPs, whatever. So, this is your first guide where you should guide your investigations. Mind you, these investigations can be very, very costly for patient at times, ranging into thousands. And the peripheral smear guides you to the approach to your diagnosis. So, you can have a step-by-step approach where you can have a peripheral smear, plan one investigation, plan subsequent investigation, or you can at times you need to plan for all the investigation in one go. That's why peripheral smear becomes very important as a guide to your further investigations. With this, I'd like to thank and over to you, Basu, sir. And with good inputs, I'll share my screen. So, yeah. Pretty visible?
Yes, sir.
I'm audible, so clear?
Yes, sir.
So, shift this. Yeah. So, good afternoon, everyone. And today we have another session. This is a kind of a repeat session for me. I've done it with the former batch of students. And so we have 5 students here and the rest of you are attendees. So this will be a kind of an interactive session. And so we will go one by one. So it depends on this. For anyone, what does this picture tell you about? Anyone knows about it? Yes, Viral, you want to answer?
Sir, is it WPC?
Okay, this photograph is actually very, very significant. This was the first description in literature in way back in 1845 of a case of a leukemia. You see the panel on the left. Wait, let me get the pointers correct. This was fresh blood. Those days there was no staining, so it was just a drop of blood on a microscope. Imagine around 200 years ago. And this was the fresh blood, and then acetic acid was added, and this is what came up. So this is a particular case of florist, middle-aged florist who had a big liver and spleen. And that time leukemia was not known, so it was the paper went reported as suppuration of the blood. There were so many WBCs. Simultaneously, Virchow also diagnosed. So this was the first description of leukemia, the morphological description of leukemias. I would request you not to ask for annotations, please. I will not be able to do that. All right. So again, the question now: what might a blood film or a peripheral smear help us do? Now, this I want an answer from all of you, 5 of you, one by one. Dr. Mukul has given a brief of introduction. So just tell me, why do you need to do a peripheral smear from a pathologist point of view? What are the conditions where you want to do a peripheral smear? Yeah. Sheetal? Sheetal is not there, right? So Sheetal is there.
Yes, she's
yeah.
for anemia, infection,
For anemia. So
Anemia.
diagnosis of a disease, right?
that is for anemia,
Okay.
that is for infection, during malaria, or any hematological malignancy, acute leukemia.
Okay. So other than anemia or diagnosis, any other conditions or any other situation where you would like to do a peripheral smear? Okay. Anyone else? Sort of?
Yes, sir. In lymphoma cases,
Yeah.
any-
All of those are
any
definitely
kind
for diagnosis of a disease. Anything other
Yeah.
than diagnosis?
Sir, for parasite infection.
Okay. So again, diagnosis. Other than diagnosis, is it always only for diagnosis? Anyone? Imagine you're sitting in a lab. In
Yes,
your
sir. We can
lab.
monitor the treatment as
All right. Monitoring of treatment. Very good.
Yes.
Okay. Now I'm giving you a situation. You're sitting in a lab, and of course you start with these cell counters, right? So anything that tells you I need to look at a smear.
Abnormal count.
Yes, so that's another thing when you have to validate what the cell counter is giving. So basically, if you look at it, you diagnose a disease, you support a provisional diagnosis. Your clinician, Dr. Mukul, has said to you, hey, look, I think this is a case of an acute leukemia. So you're supporting a provisional diagnosis. You're offering a differential diagnosis. Any situation where a peripheral smear gives you the differential diagnosis? Can you think of a condition? By looking at a peripheral smear, you tell, okay, this patient has either this or this. Anyone?
any leukocytosis cases, sir, like in any we can in myeloproliferative neoplasm, we can easily say just by looking at
Yeah, that is
this
for
is the case of
diagnosis. One condition
leukocytosis.
which I think gives a good provisional diagnosis is, let's say, something like you see spherocytes in the smear. Spherocytes, you know, either it is hereditary spherocytosis or it is acquired autoimmune hemolytic anemia and so forth. So that's when you provide a differential diagnosis, provide a path for which the clinician can. Then, as you rightly said, monitoring diseases, giving information on complications, side effects, etc. Then this is also very important: validation and explanation of cell counter reports. And at times it tells us quite a few things that no automated instrument as yet can tell us. Okay, another little question to all of you: how many peripheral smears do you? What is your policy in your lab? So whether to do peripheral smears? How many cases do you do peripheral smears roughly in a day's thing? Do you do peripheral smears for all CBCs that come to you, or do you select? Anyone?
We select on the basis of CBC findings, and otherwise they
Do the peripheral smears in all the cases. Okay, fine. You
Yes.
select based on the CBC findings. Is that the only reason when you select the CBCs or the peripheral smears? Ask you to, right? Clinician can also ask you to. So generally, a blood film helps us to opens the window of the world of clinical diagnosis. So basically, there are two indications of doing a peripheral smear. One that is initiated by the physician. The physician himself says that, okay, based on the clinical indications, based on the abnormalities of a past blood count, he will advise you. He will ask you, please get me a peripheral smear to check it out. This is what I'm thinking. Am I right or wrong? So that's one major chunk of physician-initiated requests, right? The other reason is yes, when you are looking at laboratory reports and you want to, again, I'm getting too many annotation requests. Please do not do that. And generally as a curiosity. Now, when we were training about 30 years ago, if not more, 30, 40 years ago, we had to see the peripheral smear of all the cases that came. And we did, when I was training in Maulana, we had a big load of hematology. Each and every case that came, of course, cell counters were not yet developed so well. So we had to see. So that gave us a good idea about looking at the peripheral smears. Also, many labs have certain consensus criteria, right? If your values are, depending on the analyzer that you're using, if each lab should have its own consensus criteria. Right? If your lab value is at this level, MCV less than 70, we will make smears for all. So this is a good the consensus criteria. This journal, I'll keep the articles also available for you. Has a good write-up on what consensus criteria should be. Some examples: platelet count less than 1 lakh, platelet count more than 10 lakhs. The machine doesn't give out differential count properly. So those are certain indications where you have to make a peripheral smear. But I still feel the first year PGs, when you join, don't hesitate from making peripheral smear and looking at it. You need to master what is normal. That's what is expected of you at the end of the first year. Say that this is normal and this is abnormal. If you can do that much, and that comes with repeated practice of seeing as many peripheral smears as you can. Correlate with the clinical history, correlate with the histograms, so the automated CBC parameters usually helps you in resolving most of the issues. There are again please note down these articles, which they're slightly old. Barbara Bain's the beautiful article on how to report on a peripheral smear, though of 2005, is of considerable use and value even today. And there are two more articles, both in the International Journal of Lab Hemat, which has given us certain guidelines for how to report on a peripheral smear. So let's start at the very beginning. Our observation starts with looking at the smear. Whenever you're picking up a smear to put it under the microscope, just have a look at it. It gives you a whole lot of information. I'll be showing you many such cases where with just looking at the smear, you're able to tell at least something about the case. So now there are 4 ones. Can anyone tell which is what? What is this one? Which of them is normal? Suppose I start from here, A, B, C, D. Which is normal?
A.
A is normal.
Yes.
Okay, if A is normal, what is then B and C? A, who said A is normal? Are you living on the high altitude? Someone Guwahati chap? No, A is not really normal. This is the rough. B is normal. A is obviously erythrocytosis, the polycythemic. This one? This is anemia, right? This one? B? Yes. So based on the gross morphology itself, if you look at a child with a newborn baby, this would be how the smear would look. Okay, this is something that would probably be looking at. This is basophilia that is there is something that you would expect in a gammopathy. Right, perfect. Okay, we are aware of where to look at the smear. Somewhere at B, this is called the zone of morphology. Somewhere between the tail and the head. Don't look at too much in the tail. Don't look at too much in the head. This is for morphologic assessment. But there are instances where you need to have a look at the tail and the edge also. Any reason why you need to see the tail? One condition where you must look at the tail. Anyone?
That's it.
Okay, filariasis, yes. Something else more routine.
Platelet count.
Yes, platelet clumps. When you have to assess for platelet clumps, you're not getting too many platelets. Tail is a good part. But basically, for morphologic assessment, this area is called the zone of morphology. Okay, all of this is the area where the RBCs are just stuck to each other. They should not be like this. They should not be like this. They should not be like this. Look at the lower quadrant. All these areas, you should not look at the slide for morphologic assessment. You have to look at an area where the RBCs are separate from each other. Right? I'm sure you all know that. Okay. So what are the features of a well-made smear? The color is important. What is the color of an RBC? What is the color given to an RBC? Does it have a name? Anyone? It's called buff. The color is buff. So this is how it is. WBC nucleus purple to blue, cytoplasm pink to tan. So what the stain is. What does this reflect? What effect is this? Does the stain have these shades of color? What is this called? This is Romanovsky effect. Very good. This is known as the Romanovsky effect. That's the beauty of this Romanovsky stain. It incorporates both the acidic and the basic component and gives you a various shades of color somewhere between pink, purple, orange, all that. Okay, so that's called Romanovsky effect. So this is what is the normal color. Now suppose you have a slide like this. What's your thought? These are gray. Slide is very acidic. The pH is extremely acidic. So this is something where you might miss certain morphological terms, especially in the WBCs. You might miss out on parasites, etc. Okay. So now let's look up some slides. You have a routine checkup. It's a routine case that has come to you with these values: 2.4, TLC of 500, platelets of 2000. So what's your first thought? You're sitting in the lab, you get a CBC. Beg your pardon?
Pancytopenia. So it is a case of pancytopenia.
Case of pancytopenia. Perfect. What would you look for in the smear?
Yes.
No, see, the counts are markedly reduced. So what's your first
Yes.
thought?
Organomegaly.
You look for organomegaly. Okay, as I said, it's a routine. The patient has just come for a routine, let's say one of those master checkups, and you get this value. Soon your technician is going to say the machine has got clogged. Look for clogs. First and foremost, put your slide under the scanner view. And what are these? Fibrine strands. Okay, so this is again something that you do when you start with a case of pancytopenia. Suppose it comes like that. So at a scanner view or at a 10x, what all do we look for? We look for the distribution of cells. We are able to select out 10 good areas, low power field. You can find out about rouleing, you can find out about agglutination, you can look at platelet counts, and you can pick up the big parasites like filaria. So at 10x, first thing we do when we see a count, if it's normal, these are things that you will be able to identify. If it is such a thing, look for fibrine strands. And if you have a fibrine strand in a smear, reject that sample. Say that the counts are not correct. So that is one of your reasons for rejection. Okay, so the first thing when you get a count like this, look at the smear for this. Otherwise, if the counts are normal or whatever it is, you use your low power or 10x to identify the distribution of cells and select areas where I'm going to look at further into for the various things. Rouleing, agglutination, platelet clumps, and parasites can be picked up at 10x. At 40x, we do our differential count. Okay, please do not do your differential leukocyte count on an oil immersion. You will keep running into the same cell over and over again. So 40x is meant for the RBC morphology and for doing your differential count. Oil immersion, again, you just confirm your RBC and WBC morphology can be confirmed, but more important are finding inclusions and parasites. So that's how we look at a smear, right? So for convenience sake, I will discuss RBC, WBC, platelets separately, look for parasites and learn to appreciate artifacts for this. But otherwise, remember, you can have a mixture of findings. So again, this is basically the smear provides an accurate assessment of RBC size, shape, distribution, inclusions. You must be able to appreciate artifacts from normal. Some of us have this habit of being a semi-quantitative approach on each of the finding that we get, +1, +2, +3, plus. We need to be very, very rational about it. So guidelines will follow. And you please have standardized terminologies. You know, sometimes you call them electrocytes, sometimes you call them pencil-shaped cells, spur cells, or acanthocyte burst cells. In your lab, in your setting, have a standard uniform approach to your reporting. That goes a long way in your understanding as well as in the understanding of the clinician. Okay. So again, these two recommendations are good. Please have a look at them. I prefer to keep both these articles with me on site always when I'm reporting out or when I'm reading. And this is how it is reported. Each of the parameters have certain that what are normal, which is non-specific, 1 plus, light of view, 2 plus, and 3 plus. When do we call each of these parameters? Look at it. Up to acanthocytes. Burst cells, more than 30% report. In each of these, so this is a good guideline to have for you when you're starting with your morphological assessment. See a Howell-Jolly body, you must report it. See an oval macrocyte, must report it. Don't wait for looking at too many of them. And this is what tells you that if certain things are few or 1 plus based on the previous, they're not applicable. You don't have to bother too much. But 2 plus and 3 plus, you must start reporting, excepting for schistocytes. Schistocytes, even 1 plus, that is 1 to 5%, has to be reported, right? Even if there is a single or a very confident schistocyte you're about, you must report it. For all the mild lesions, the mild variations can be overlooked. Okay, that's important. Okay, so what does this tell us? This particular slide tells you how to look at an RBC, right? These are obviously microcytic, and we look at a nucleus of a small to judge the size of the RBCs. The microcytosis, this is macrocytosis because they're bigger than that. So always identify a lymphocyte and then decide. Again, I'm saying that currently you have your cell counter values in most situations, which will help you corroborate. So if you're finding, we will discuss that in a while. So this is how you look at microcytic hypochromic cells, and these are the guidelines when to report on microcytosis. Less than 60 femtoliters or more than 50% of your RBCs are microcytic, the variation that is significant. This tells you about hypochromia. What else does this slide tell you? You notice that they're microcytic, hypochromic, with some degree of anisocytosis and isopoikilocytosis, with a good number of elongated, or these are what are called the pencil cells. So what do you think is your diagnosis of this smear?
So iron deficiency.
Okay, suggestive of iron deficiency. This is how a microcytic slide would look at microcytic hypochromic for an iron deficiency. And this is how we report on hypochromia. Okay, mild, moderate, severe. You have to assess that. So quickly tell me the causes of who will do that? Priya? Quickly tell me the causes of microcytic hypochromic.
Sideroblastic anemia.
I do not want you to remember mnemonics for this. That is when you answer as an undergraduate and you answer questions. You have postgraduates, you are clinicians. So tell the common causes first.
Iron deficiency anemia is the
Right.
cause.
Next.
Okay. And then
Yes, so thalassemia and the hemoglobinopathies. Then
consider like anemia of chronic disease and
anemia of chronic disease. But remember, they are not purely microcytic hypochromic. You get microcytic hypochromic RBCs, but they are not purely microcytic hypochromic. And then finally, sideroblastic anemia. So your CETA can be turned this way and that way to get an answer. So please, all of you postgraduates, forget about ramming up disorders and mnemonics when you are learning. Okay, you are learning for not passing an exam. You are learning for patient care. Okay, so these are generally the common causes. Anemia of chronic disease comes way down in the disorder because we have to make a differential diagnosis, give a sensible differential diagnosis. The case of iron deficiency anemia, if you say this looks like lead poisoning, you are misleading your clinician. So keep that in mind always when you are looking at a slide. Certain hemoglobinopathies, HBE, HBD, often have microcytic hypochromic indices. Right. So this is again a case that I've shown before. We have two cases, both similar hemoglobin, but with here. Both of them are women, ladies, one pregnant, and you have these indices that help you out in your workup of the patient. In this case, you probably don't have to really look at a peripheral smear. Many a times your indices help you. So this lady on the left has menorrhagia, hemoglobin 9.5 with microcytic hypochromic indices. RDW is increased, RBC is low, and Mensa is more than 13. So you know that you're dealing with iron deficiency anemia in this side, and this is the typical appearance of a thaltrate. Now, mind you, don't say beta thaltrate, even alpha can be of a very similar morphology, right? So you make a smear, and you find that this has the typical anisocytosis of iron deficiency. These are all more or less uniform, fine target cells here and there, stippled RBCs here and there. So what next would you do? For this, if you want, you can get a ferritin done to confirm yourself, and here you would go in for an HPLC. So this is the idea in which this is again what I said, help you out in differential diagnosis. Peripheral smear, you're not just diagnosing, here you are going to give a good differential diagnosis. What about this? 5-year-old boy, you have a good history provided by your clinician, so you're comfortable. Now what does this, where would you take this case? This is also microcytic hypochromic. Remember, but the degree of
Thalassemia major.
yeah, this is what you would get in a thalassemia. Probably major, thalassemia intermediate or major. There is a tremendous amount of anisopoikilocytosis. So here at this point of time, if you say I'm dealing with possibly microcytic hypochromic iron deficiency anemia, their algorithm goes out. Okay, so this is something that you would expect in a thal major with nuclear RBCs, lot of targeting, severe degree of anisopoikilocytosis. Right? What about this one? 22-year-old girl, hemoglobin on the lower side, NCB is very low, and this patient she was a nursing student in our institute. She had taken iron ever since she started NRK, and she was continuously with iron, but hemoglobin did not. So what is it in this smear that tells you, gives you a clue to the diagnosis? Anyone?
This target cells.
Now you have again kind of uniform microcytosis. They're all more or less small, and you see these target cells. So where does that lead you? What do you want to do in this situation? One investigation you will do, which you can do there and then. Straight away HPL, that will give you a boost your own. Hemoglobin low, chronically anemic. One test that you want to do, which you can do with your own reticulocyte preparation. Denser index and all is available on the HPL, on the CBC will do. But something there and then, and what would you look for in your reticulocyte count? This is this particular girl never had a retic preparation done. She was roaming around with a low hemoglobin, and here it is. This what does this show? This shows the golf ball appearance, not reticulocytes. This shows the golf ball appearance of hemoglobin H. So you could diagnose alpha thalassemia. Yes, your HPLC would definitely give you a diagnosis, but there and then to boost your confidence, inform your clinician, hey, this looks like this is not iron deficiency anemia. This looks like a thalassemia, and looking at these pathognomonic golf ball inclusions, you're confidently saying this is HPH. Okay, and thereafter your electrophoresis or whatever you have, HPLC would follow. Okay, what about this?
Spherocytes are there.
Okay, spherocytes are there. Anyone else has any other opinion? What would you ask your clinician or anything you would want to know?
Some transfusion therapy, blood
Very
transfusion.
good. So this is the typical appearance of post-transfusion. Notice the background RBCs are all microcytic hypochromic, and you have these very well hemoglobinized, almost like spherocytes. Spherocytosis doesn't usually occur in the background of iron deficiency. So this is what you get in a typically post-transfusion smear. You may not always get a history, but if you have this dimorphic, many times your CBs, these red cell histogram may show widening of the RDW, may not show a very typical bifid or a double peak, because if it's micro and normal, usually it's missed out. But this is a giveaway. These kind of small, contracted, but poorly well hemoglobinized, hardly any central pallor is a clue. And look at the two distinct population of cells. So this is the case of iron deficiency anemia who's had a recent transfusion. Okay, so that would be what about this? Are these hypochromic?
No.
More than 1/3 is occupied. Okay,
Water.
Mandeep has said that yes, this is a typical water artifact. By chance, while you're staining, some water has fallen in, or it is too diluted a stain. This is the typical what you get in water artifact. This is a classical example of water artifact. And notice the kind of contracted or irregular shrinkage of the cells and the punched out holes. So that's water artifact. Okay, so from microcytosis, let's move on to a case where your RBC indices, NCB is on the higher side. So what are the general causes when you get a macrocytic?
B12 deficiency.
B12 and folate. So it could be megaloblastic or non-megaloblastic. Very good. So this is how your usually CBC would look like, slightly on the lower side of WBCs, lower side of platelets. And so you have a macrocytosis with an NCB of 111. You make a smear. What do you look for? First and foremost.
Macrovenocytes.
Okay. Anything else? You're not getting macrocytosis. Anything else? Anything else could be the cause of an NCB of 111.
Correct.
Folate formation won't increase for NCB too higher. Anything else that causes, you don't know anything about the history, you make a smear. If you see macrovenocytes, fine. But if you see polychromatic cells, that could be your cause for high NCB. So that's the first thing we rule out. Are we dealing with reticulocytosis, or are we dealing with a true macrocytic anemia? Okay, so if it's true macrocytic, these are the causes: megaloblastic, liver disease, aplastic anemia, hypothyroidism, etc. But if it is polychromatosis, all these conditions, post-hematinics, reticulocytosis, hemolytic anemia, at times your NCB may be high. So keep that in mind. The first thing that you look at the smear for. This could be another. What is this happening? Agglutination. Agglutination can also be reflected on the numbers, often with high MCD and very abnormal MCHC. MCHC around in 40s, 39, 40, 45. That's again a feeture of agglutination. So your cell counter compared with your peripheral blood aids you in your differential diagnosis. This is typically of megaloblastic anemia. I hope you know what is hypersegmented neutrophils and oval macrocytes. At times you may get gathering. How is jolly bodies? This erythropoiesis can be seen. So this is clear cut. So what would you do at this point of time? You have a peripheral smear with this. What would you do next? Anyone?
Sir, we'll advise for vitamin B12 assay.
Okay, you would advise for B12 folate assays. What I meant to say is this is no longer an indication for doing a bone marrow. Even if B12 folate assays are not available, empirically start the patient on B12, supplement it and check for response. Right? Okay. So this is a 10-year-old boy with pallor and refractory anemia. Okay, again MCD is on the higher side. Okay, this is a smear. Looks. I'll show you some more in our immersion. Any hemoglobin of 4, right? 4.5. This is what you're getting. What are you missing? What are you looking? They are predominant normal to macrocytic, no shape changes, no ovalocytes, no station, but something you look for, which you're not getting in all these fields. Any?
The platelets are less.
I don't know polychromatic cells. I would be desperately looking to see a polychromatic cell, and I don't see polychromatic cells. Retic, I find out is 0.1. So this, what would you do next? Which will give you the diagnosis. You do a bone marrow, and you will find red cell atresia.
Yes.
Right? It's not aplastic because your TLC and platelets were pretty good. And so this is pure red cell atresia. So this is where again your peripheral smear, a negative finding on a peripheral smear would help you in your diagnosis. Okay, so whenever you're looking at a patient with anemia, make a note of not just of the morphology, make a note of the polychromatophils, always do a retic count, and then that helps you in your diagnosis. So various causes, as we have discussed, all of these, megaloblastic anemia, aplastic anemia, liver failure, hypothyroidism, and MDS and CDA also generally present with macrocytosis. Let's observe some more. Yeah, this is not of course the case. That's one of the images in blood. Agglutination. Always go back and look at the blood sample. You will find agglutination. So this is one again agglutinated RBCs. What would you do in this situation? Anything simple, straightforward?
So
You got a
incubate,
space
We will put incubator.
Okay, Mandeep, very good. You will warm the blood. Simple, straightforward there and then you will do warm the blood. And this is what you will do. This was when the sample came, you couldn't really make a smear, warm the blood, and this is what happens. This is the same case, agglutinated, and when you warmed it, everything is clear. Right? So this is a simple procedure to confirm agglutination and also report. When you know that when you have an agglutinated sample, it often becomes difficult to report on that sample. So this was a patient, resident of Delhi, elderly male, winter month, presented with jaundice and bluish discoloration of the fingertips. You see agglutination. What else information is this peripheral giving you? Anyone? Yeah. Lumens, right? Anyone else? Right. There's a lymphocytosis, right? Monotonous population of lymphocytosis. So you're dealing with a lymphoproliferative disorder, possibly CLL, which is brought about this agglutination. What about this? 65 male
Next one.
osteolytic lesions in the skull. This is classically what is called Rouleau formation. At this point of time, if you are not able to make a good smear, you can use saline. You can dilute it with saline, the blood, and make a smear. We generally don't do it because Rouleau formation gives you a lot of information as such. So this was another case, patient with renal failure. And again, I'm seeing Rouleau formation. Right? What would I look for? When you see Rouleau formation, what is the next thing that I'm going to look for? When I'm doing my differential count, you want to see for?
Plasma.
Yes. Viral Sakshi, all of you please wake up. Okay, so I'm going to look for plasma cells, and there I found the plasma cells. So Rouleau formation is again a very important finding. Also with the Rouleau formation, mind you, you find these kind of background color to the slide, slightly eosinophilic color to the slide. That will be always seen when there is high levels of immunoglobulin in the circulation. Okay, so this is an important Rouleau formation and causes again. I'm sure all of you know. You get that in myeloma, you get that in Waldenström. You also get it in conditions of hyperfiltrinogenemia. Hence, in chronic inflammatory conditions, Rouleau formation may be there. Mind you, a mild Rouleau formation may be seen in anemic states because of dilution. You get a mild Rouleau formation in anemia also. So keep that in mind. Any situation where you don't get a Rouleau formation, we're not finding the Rouleau. See, normally in a smear when you're making, the body of the smear has Rouleau, right? That's normal. They're all stuck to each other. One situation where even the body does not show Rouleau formation. The body of the smear doesn't show Rouleau. Two conditions actually. Spherocytosis. In spherocytic samples, you generally don't find Rouleau formation, or if your RBCs are sickle, good number of sickle RBCs, Rouleau formation is missing. Okay, let's look at the poikilocytes. So this is where you provide a differential diagnosis. What is the chief complaint of this slide or chief finding in this slide? Spherocytes, right? Observe the spherocytes in the smear. So that's the differential diagnosis. What is the differential diagnosis of spherocytosis?
Diabetes, phagocytosis,
Hereditary spherocytosis.
Spherocytosis and
hemolytic anemia,
Autoimmune anemia.
autoimmune.
immune hemolytic anemia, right? Not all hemolytic anemias are going to show spherocytes. So immune hemolytic anemia and hereditary are the two broad, but they could be seen in many other conditions. So we have this child who presented to the gastroenterologist with intermittent jaundice, splenomegaly, hemoglobin 9, white cell count normal, platelet count normal, MCV 80, MCHC is prolonged 39. So one of the conditions where we use the word hyperchromia. Don't generally use it, but increased MCHC. So what is the likely finding on the peripheral blood? Spherocytes. Another condition where you get increased MCHC other than spherocytes. Mind you, it's not just specific for spherocytosis. You can get increased MCHC in crenated RBCs. You can get increased MCHC in sickle cells. You can get crenated MCHC high in schistocytes. All of them where the RBCs get kind of concentrated, dehydrated, right? So that's spherocyte. In fact, if you look at it, I mean, in my experience, I'm sure it's others. In Indian hereditary spherocytosis, MCHC is not high. Probably there's some element of iron deficiency that still is lurking in the background. I've rarely seen an MCHC touching 39 or 14. Our cases of hereditary spherocytosis, but MCHC increase I have noticed, of course, in agglutinating diseases or also in sickle cell and all. MCHC is often very high. So once you have a spherocytic anemia, spherocytes are there. You have to look for whether they're artifactual or actual, and this is the clue that I was talking about. Lack of Rouleau formation in the body of the smear. There are two spherocytes. So if you have a spherocytic anemia, you can obviously go with the history, whether it's a hereditary spherocytosis, they're generally uniform shaped, uniform sized. Retic is compensated in, unless the child is in hemolytic crisis or some form of a crisis. Retic is usually compensated. DCT, ICT will always advise negative osmotic fragility and EMA. So your diagnostic workup starts with your peripheral smear. In contrast, what about this child? 14-year-old boy, refractory anemia, transfusion dependent, retic high. Again, notice the spherocytes, but also you notice something here. Not too many stomatocytes here and then. Yes, I'll show you better cases of stomatocytes. What are these cells? They have a little nipple-like protrusion, not really blister. We'll discuss that. Any idea what this shows? In which condition you get such? Okay. Then again, I'll show you something. Hand mirror, no. Band 3. Hereditary spherocytosis due to a band 3 abnormality often shows this little kind of a protrusion from the RBCs. Of course, this can be seen as we'll discuss in G6PD also, but there it is slightly different. Yeah. In contrast, when you see a patient, a female patient with high color urine, LDH raise, sorry, it should be LDH, not LCH, I'm very sorry. Here, you see a lot more of spherocytes, and this is what you usually get in autoimmune hemolytic anemia. Here, also another clue to autoimmune hemolytic anemia is this. So setting around the WBCs. The RBCs tend to stick to the WBCs as they stick to each other. And so they are varying size spherocytes. Retic is often high, and you can get a direct Coombs positive. So that's how you differentiate between spherocytosis, hereditary inherited versus an autoimmune. What about this? Newborn, jaundice, classical, ABO, and RH. Both will cause spherocytes. RH has a lot more of polychromasia and NRBCs, and these spherocytes are abundantly seen even in newborns. So it's not just hereditary spherocytosis and autoimmune hemolytic anemia. There are many more other causes. So usually it's absent in normal adults, and when it's 2+ or 3+, we report it more than 20%. These are two common causes, but again, spherocytosis. Remember that slide with iron deficiency on transfusion? Transfused blood looks spherocytic. Hemolytic disease of newborn, mismatched transfusions, post-splenectomy, and in these conditions of microangiopathic hemolytic anemia, severe burns or Clostridium infection, you get what are called microspherocytes, tiny-looking spherocytes, small ones. Okay. Routine checkup. 61-year-old lady. This was actually one of our faculty whose entire family had come for a wedding, and one of them, there were 6 or 7 siblings, elderly, all of them in their 60s and 70s. One of them just came to us for a routine checkup, and that happens. So the consultant tells you, "I just get my sister's blood done," and this was the picture. We then subsequently tested all 7 of them, all of them had this. And they were otherwise hale and hearty, healthy individuals who would have had. So this is electrocytes of hereditary electrocytosis, right? I would not use the word pencil cells for this. These pencil cells, let's reserve it. It's not a good prescriptive word, but let's reserve it for iron deficiency. Okay, these are all electrocytes, well hemoglobinized electrocytes with kind of blunted edges. So you can see it in any conditions. Okay, in electrocytosis, it is often very high. At times, you get elongated cells in thalassemia, iron deficiency, megaloblastic, post-splenectomy, myelofibrosis. So you have to look at it in the context of what are the cells finding in the smear. If it's predominantly electrocytes, about 20, 30, 40%, then it's yes, it's electrocytosis. And you can investigate accordingly. What about this? This is not my case. I have a case which I'll show you. This was from the path. This is what is a stomatocyte. Okay. These are all stomatocytes. Majority of the cells are showing a stoma. Here you can give a very specific diagnosis with the history with the clinician Southeast Asian stomatocytosis. Mind you might wonder, is it important to diagnose? Adults are usually asymptomatic, but homozygous stomatocytosis can be symptomatic. Present with neonatal jaundice, present with hydrops, homozygous in infants. So though it's kind of said to be a very asymptomatic condition, but homozygous forms are they can present with features of jaundice up to even hydrops. Okay, so that's an important diagnosis, and this is something most of the time just a peripheral smear diagnosis. You really don't need to go beyond diagnosing a Southeast Asian stomatocytosis. Okay. This condition, this patient girl with jaundice, you're looking at sickle cells, so you can make out the diagnosis easily on a smear. Any other information this particular slide is giving you? You see nice sickles. Something else anyone can point out? Sickle cells, yes.
Crystals.
Okay, right.
Target cells.
Crystals, not sheep. Okay, very many target cells.
Yes.
Something else.
Are
What
there
is
some crystals?
arrow shows? This cell.
Holland
cell.
body.
Yes. So what does Howell Jolly body tell you?
Sir, it's an autosomal atomic case.
Yes, the patient is also having features of hypospanism or expanism. Okay, so this is some information that you can garner from your peripheral smear. Okay. Anemia, jaundice, and bleeding. Possible causes? What are these cells?
Cystocytes.
They are schistocytes. Mind you, they are not artifacts, they are schistocytes. The other RBCs are normal. So they are schistocytes. And that's a finding of ominous significance. Dr. Mukul was telling us that we need to report instantly, as early as possible. This is one condition, especially TTP. If you do not manage it on time, the patients can have a very, very bad course of the disease. So this is something we train our residents that you must be able to identify a schistocyte. And then it's important because the schistocytes have varying shapes and sizes. So you have to identify how they all look like. It's a medical emergency. And this is one condition where even 1%, if you see, you should report it out, provided there is no other abnormality. Now look at this slide, you see polychromatic cells and you see schistocytes. You do not see any other atypical RBC morphology. So this is what is the characteristic feature of MAHA along with thrombocytopenia. So this is again the same two articles. There are articles which have discussed how to look at schistocytes. They can have various forms, the typical helmet shape, the keratocyte, the triangular schistocyte, the microcrescents, and also microspherocytes. So this is the spectrum of schistocytic changes of fragmented RBCs, which must be appreciated. So it's a finding of ominous significance. You must grade even the bare minimum. So what is the PS finding of MAHA? Thrombocytopenia, NRBCs, and when the main morphological feature is the schistocyte. If you're having teardrop cells, if you're having target cells, if you're having microcytic hypochromic cells, it's not a schistocyte. Other than these three, MAHA, of course, we get this similar changes in PIH very regularly. Metastasis, especially mucin secreting adenocarcinoma, at times in prostatic valves and snakebite. You get a similar peripheral blood finding. This one, 23-year-old girl with ingestion of insecticide, severely jaundiced. I've pointed the arrows to something. These are bite cells. So you need to differentiate them from fragmented cells or schistocytes. Okay, and these are what are called the blister cells. Right? A lot of polycromatic response is going on. So you know you're dealing with a hemolytic anemia. We have this case that I keep presenting. Patient of bullous pemphigoid for 3 months, started on Dapsone and noticed the hemoglobin drop and the retic rise over a period of 1 month, and peripheral blood showed fragments. So Dapsone and many of the other sulfone group of drugs often cause bite cell anemia. So what do you do? What stain is this? What is the stain that you have done to demonstrate the so-called bite cells? This is a Heinz body preparation. So you do a methyl violet or a crystal violet, a very simple stain. Reticulocyte stain that we do often, but it needs a kind of supravital with reticulocyte, the brilliant crystal blue, needs prolonged incubation. Better is to use stains like crystal violet or methyl violet, the Heinz body status. This is a very simple stain. Just 5-6 steps in methyl violet, and you're able to pick up the Heinz bodies. Okay, so G6PD induced hemolysis, I'll not go into the theoretical details. It's basically the disulfide links between the hemoglobin and the cell membrane, which causes the damage to the membrane. Why are there bite cells? What is the pathophysiology of bite cells?
Fragment of
Anyone? Why does it get? Okay, anyone? All of you are spleen removing the Howell Jolly bodies. If the spleen removes the Howell Jolly bodies, how do you get this blistering? Why is the membrane visible? If the spleen has taken away the Howell Jolly, not the Howell Jolly body, the Heinz body. The pathophysiology is the deranged, damaged hemoglobin, the self hemoglobin precipitates on the membrane, and that is not stained by your Romanowski stain. Okay, so this is the of a blister that forms. This part of the RBC has that deranged hemoglobin, the self hemoglobin, and that is not stained. Okay, once this goes into the spleen, that is picked up, and then you get a bite cell. So it is not just splitting of the spleen that causes the oxidative damage. The damage that occurs to the hemoglobin precipitates is unstained, and that is the basic pathogenesis of blister formation. Thereafter, the spleen picking takes place, and the spleen you get a bite cell, right? And that's how you have these Heinz bodies visible. If the spleen had taken them off, there would be no Heinz body visible, right? So the basic thing is lack of staining of the sulfated hemoglobin, right? This is another condition. This is again a similar situation where instead of the bite, you see that little hemoglobin as a pincer, as a little protrusion. This is again another feature that you can see in G6PD. It's not that always it is a bite. At times it is a little thing sitting on top of the RBC. So this you condition get in G6PD deficiency, oxidant drugs, chronic liver disease, Wilson's disease, post-nectomy, you might get a bite appearance. My question now here is, would you do a level of G6PD? When do you do the G6PD assay? At this point or later or when? Anyone?
Sir, later.
Later.
Because,
Any reason why?
sir, because in acute condition, the reticulocyte may give a false negative result.
Reticulocytes are generally rich in G6PD. It is the adult RBC, the G6PD content in the adult RBC, which is one that is deficient. So in an acute hemolysis, the retic counts are rich in G6PD, right? So you get a false positive. You may get a positive that the patient does not have G6PD deficiency. So it's ideally to wait about 3 months, the lifespan of the RBC, and then do your G6PD test. Once the period of hemolysis is over, so you follow up with reticulocyte count, the retic is reduced, then you do your assays. Till such time, managed clinically, Heinz body is a good indicator of G6PD deficiency. So that's important. Reticulocytes are so white cells give a clue to the diagnosis at this point of time. Okay, this was a boy from Punjab, a sick boy, recurrent jaundice, splenomegaly, 10-year-old. Again, we come back to the target cells. This is a good clue to hereditary hemolytic or hemoglobinopathy conditions. Target cells are known is very, very non-specific. Basically, there is a ratio difference between the membrane and the cholesterol or the lipid content, and or could be due to a hemoglobin deposition, and so that the typical biconcave appearance of the RBCs are lost. You can grade it, and there are a wide variety of conditions. Thalassemias. What disease is this? Full of target cells.
Thalassemia.
This is hemoglobin C. Hemoglobin C has these crystals of hemoglobin This is a disease that is more seen in the African population, not so much in India, but with transmigration, we are picking up cases of hemoglobin C. That is sickle cell, and this is a post-splenectomy smear. So you do get target cells in a wide variety of conditions, even severe iron deficiency anemia, thalassemias, hemoglobin C, and liver disease, alcoholic, obstructive, post-splenectomy, premature infants can show target cells. Again, this is an important thing. Target cell is an artifact of slow drying over anticoagulation. It's a very common artifact. Along with cremated cells, target cells is a common artifact. Now this one, confirming a suspected diagnosis. This has come from your neurology. 21-year-old girl, parents are second cousins. The child, the 21-year-old girl presents for the last 6 months with grimacing, dystonia, facial tics. CBC is normal, absolutely normal, and PS has never been done before. What do you think you will find on the PS? It's come from neurologists.
Acanthocytes.
Yes, very good. Acanthocytes. There's an entity called neuroacanthocytosis. So your peripheral smear is giving you a diagnosis which your clinician was suspecting. Chorioacanthocytosis, McLeod phenomenon, A beta lipoproteinemia, all shows acanthocytes. So otherwise, acanthocytes, I hope you know how to differentiate them from a birth cell. They are a significant finding of ischemia along with Howell-Jolly bodies. Okay, all these alcoholic liver disease, again, non-specific, doesn't give you a diagnosis, but it's definitely useful when you're suspecting neuroacanthocytosis. Look at the smear carefully, and acanthocytes are visible. Birth cells are kind of non-specific. Significant finding in renal failure, uremia, liver disease, and dialysis, and these are called echinocytes. That's how you differentiate, right? Okay, so we have acanthocytes, we have echinocytes, spur and bud. Spur cells have certain diagnostic significance, bud not so much. What are these? You see a smear like this. What's your thought? Almost all cells are. So what is it? It's an artifact. It's an artifact because if you look at it, a true echinocyte, it's not that 100% cells will be echinocytes. There are normal RBCs in the previous slide. Acanthocytes are normal RBCs. So this is one condition where all the RBCs are cremated, possibly a storage artifact. Your sample was collected long ago, smear was made hours later, and you get this kind of an appearance. So this is an EDT and storage artifact. So keep that in mind always. 78 AR male with massive spleen. Okay, the diagnosis is you're giving a differential diagnosis. You're giving a possibility when you see teardrop cells and NRBCs. So what is it? Possibly this is what is called the leukocytoplastic blood picture, and the marrow shows myelofibrosis. Okay, so depending on the situation, you can help out. It's a child with massive liver and spleen. This slide I showed in the last Sunday when I was taking again. Leukocytoplastic blood picture, even up to a blast. Bone marrow aspirate is a dry tap, and biopsy shows osteoporosis. So your peripheral blood appearance, this is osteoporosis with very irregular mineralization of the bone, hardly any marrow or fibrotic marrow in a baby. So this is osteoporosis. Do an X-ray and confirm. So that's the power of your peripheral smear. Whole lot of conditions, fibrosis we have seen. It's seen in metastasis. Certain other conditions, it is okay. Ashish, I'll go slow. Thalassemia, hemoglobinopathy, and liver. All right. So this is tear dropping of the peripheral blood RBCs. Yeah. So peripheral recurrent jaundice, splenomegaly, anything. This was actually a very bad slide. We were almost throwing it off. Let me just, for the sake of it, because it was jaundice, splenomegaly, let's look for parasites. We put it under oil, and this is what we saw. Any thoughts? Beg your pardon? What does this RBC show? What does this RBC show?
Esophageal stippling.
I can't hear clearly.
Basophilic stippling.
Stippling, beautiful. Stippling. Now this is not a parasite case. This is again a water artifact. Okay, this is showing basophilic stippling. So what is your diagnosis? Jaundice, recurrent jaundice, spleen, stippled RBCs. These are not cabolins. Someone is commenting on these are not. This is again, as I said, water artifact. I'm seeing large cells with stippled RBCs. Someone said thalassemia. Is the background looking thalassemia? So what are the causes of stippled RBCs? Let's see one by one. Okay, yes. Lead poisoning, yes. Thalassemia, yes. So some of the causes of lead poisoning won't present with splenomegaly and recurrent jaundice. Thalassemia might, but I don't see any thalassemia RBCs. They're pretty well hemoglobinized good RBCs. You can get stippling in MDS, megaloblastic anemia, etc. You also get stippling in pyrimidine 5' nucleotide deficiency. So this was the diagnosis in this case. Your peripheral blood gave you the diagnosis. Okay, yes, lead poisoning, etc. can happen, but in the context of this particular patient, this was the diagnosis that was offered, and this was found positive. So stippling of the RBCs can be seen in a wide variety of conditions. Lead poisoning, thalassemia, megaloblastic, as you said, rightly, all of them. But it is also a feature of pyrimidine 5' nucleotide deficiency. Again, another little thing about all these, inclusions and their storage can often they degenerate. When the EDTA acts on too much of these, all these inclusions, etc., even malarial parasite rings can be very difficult to find in an old blood. So that's why films have to be made as early as possible. Okay, this one. I'm not giving you the history deliberately because all the findings that point to the history are there in this. Just can you let us know about anisocytosis? Quite a lot. Poikilocytes. Okay.
Yes.
Any other changes? What are these? Just now saw them, right? Acanthocytes.
Yes.
What is this? What is this? What is this? Target cells. So you have a combination of moderate and poikilocytosis, target cells, acanthocytes, something else. This one? This RBC. Howell-Jolly body. So what do you think has happened? Can you see good number of places? Right. So this is a post-splenectomy smear. This is, if you look carefully, these are not really fragmented cells. These are not really bite cells. They're all irregular acanthocytes. Acanthocytes, target cells. These are all the senescent RBCs, which once the spleen is gone, they're in the circulation, right? You see Howell-Jolly bodies, etc. So this is typically post-splenectomy smear. So this is at times when do you look for Howell-Jolly bodies? Especially patients with ITP and autoimmune hemolytic anemias who have undergone a splenectomy. Looking for Howell-Jolly bodies is important because you say, okay, the splenectomy is active. Howell-Jolly body is an important finding. Report if you see them. It indicates hypostates of post-splenectomy. Maybe seen in megaloblastic anemia and other conditions of CDA, etc. And it is very important to look for Howell-Jolly bodies in post-splenectomy smears, especially with refractory ITP and AIHA. We've had cases where post-splenectomy, the spenunculi were there, ectopic spleen was missed, and the Howell-Jolly bodies were not seen in the peripheral blood. Post-splenectomy, in the case of ITP, I still remember that gentleman. He had to undergo another surgery, and the splenunculus was removed. Okay, so that's of course a long time ago. So what do we learn from the RBCs? The type of anemia, the hemolytic, various poikilocyte cell story, and red cell inclusions. Okay, that's a heart-shaped RBCs, entirely normal. Okay, there's no abnormality about that. Just tells you that RBCs are nice. Okay, so just quickly we'll move on to the WBCs and how looking at the WBCs help us. They add color to the peripheral smear. Yeah, we could add a lot of colors tomorrow, so this is the prelude. Again, theoretical stuff, but important when you're looking at a smear without your counter available values. And this is what helps you validate your counter reports. Always do your counts in 40x, roughly, number of WBCs in 10 fields. And this is the general dictum. If you see 2 to 4 cells, 4 to 8,000, roughly we multiply by 2,000. But if your count per high power field crosses 20, multiply by 2,500. So this gives you a rough estimate of the TLC and also helps you corroborate your machine findings. At times, new created RBCs in the older machines or some of the machines, the new created RBCs can give us spurious increase in automated WBC count and all this. If they are more than 10 in number per 100 WBCs, correct your TLC. Most of the machines are giving you a new created RBC count separately. Sysmex, sorry, etc. So if you don't have the facility in your machine of counting out new created RBCs separately, you must correct the total leukocyte count, especially if your NRBCs are more than 10 per 100 WBCs. Okay, otherwise you'll be falsely giving a total leukocyte count. Although rare, neutrophilic agglutination does occur in clots or severe sepsis, may falsely reduce the automated TLC. So that's another pitfall that you have to be careful about. 20-year male with sepsis, again, this is something that your older machines, they would mistake the monocytes for the metamyelocytes for monocytes. At times, the monocyte count would be high, and because of, so again, this looking at the smear helps you check whether differential count is correct or not. Monocytes generally we tend to miss out in our manual differential count because they usually come to the tail, they're large cells, they move out into the tail. At times, you have a differential between is it an atypical lymphocyte or a monocyte, so I better not count it, I'm not sure. And older, stored blood, the lymphocytes become larger. They have that degenerating capacity and becomes difficult. So generally, we underestimate the number of monocytes on a peripheral smear doing a manual differential count. So rely on the counter because most of the counters nowadays are able to identify monocytes better and easier. Immature granulocytes are usually not seen in the peripheral blood unless it's a premature infant. And again, if you go by the guideline, if you have these values, blasts of 1, even 1 blast is abnormal, metas more than 2, promyelocyte or myelocyte more than 1, atypical lymph, all these are abnormalities that needs to be reported. Most of the time, I find that we have a tendency to count the band form separate from the neutrophils. It is not very necessary, excepting in neonatal sepsis, where a band percentage is important for prognostication. Try and club them with neutrophils, but keep a note on the band because they tell you about the left-shifted situations. So when you have this left-shift situation, this is what, sorry. Now, what does this tell you? This smear?
Seems a bad word.
Huh?
Bad word.
It's a drumstick. Don't say these are not bad bodies really. This is just the drumstick. This is just the drumstick, indicating that it is a female sample. It's of a female. Bad bodies are typically what you see is in the epithelial cells. Okay. So also be aware of the spectrum of toxic change morphologically. That's important. It's not just toxic granules. It's the olive bodies, pycnosis, apoptosis, and vacuolation of the cytoplasm. All these together comprise toxic change when you have to look at severe sepsis cases. Similar changes may be seen in patients on GCSF. The shift neutrophils, the neutrophils that are coming out of the marrow often resemble toxic change. So be careful about that. This is a good sign to have that your patient is responding to the filgrastim or colony stimulating factor, not necessarily having an infection. So keep that in mind when you are dealing with a case of patient recovery for chemotherapy. 8, with recurrent infections. Large granules. So what's your thought? Violet and brown in color. Anyone? Still, chediatric rashes syndrome, right? Okay. This is what you get in chediatric rashes. So your WB, you're looking at the WBCs will give you your blue. A big hepatosplenomegaly, and these are the WBCs. What is the above? Vacuolation. Right? Cytoplasmic vacuoles. Neutrophils also and lymphocytes also. So what would you suspect? Not necessarily glycogen storage. Glycogen storage does not manifest in the peripheral blood, please. It's a liver thing. The other storages, lysosomal storages, mucopolysaccharidosis, all these can show. And this was a case of a Goldman disease where you do a marrow and you confirm your diagnosis. This is again a kind of serendipitous finding, but we have been able to report on it quite a lot. A jaundiced newborn, and you notice these bilirubin crystals. Bilirubin crystals inside the neutrophils. It was kind of a curiosity we thought, but then when we looked at it in a series of patients, this thing is seen in hepatic jaundice, is seen in sepsis-related jaundice, not in the indirect hyperbilirubinemia states of neonatal jaundice. This is a very ominous sign that the jaundice is severe. It's more of the conjugated bilirubin that becomes crystallized and that can be picked up by the neutrophils. Okay, 19-year-old college student, fever and cervical lymphadenopathy. To a beginner, they may look blastoid, right, like blasts. But this is something what you get in infectious mononucleosis, or the entire group of viral infection. The typical touching the RBCs, all kinds of names are given, skirt-like appearance, skirt-like appearance, etc. These are reactive lymphocytes. These are atypical but reactive lymphocytes. They are not necessarily blasts, but yes, they can be mistaken for blasts, and that is definitely a point of differential diagnosis that we have to undergo. Similarly, in COVID, we saw a whole lot of WBC changes, especially in the lymphocytes. And these cells in are called as Downy cells, type 1, type 2, type 3, some plasmacytoid, some are monocytoid appearance. So there's a variety of spectrum. These are the changes that you see in COVID, that we saw in COVID, from neutrophilia to lymphopenia, eosinopenia. NLR ratios was absolutely, every paper that came out showed NLR ratios being done, reactive lymphocytes and thrombocytopenia. A 2-month-old girl, again, not my case. Any thoughts on this? Very mature appearing lymphocytes. 2-month-old baby with cough and wheezing. Pertussis, excellent. Whooping cough is probably the only bacterial disease that shows lymphocytosis. Generally, you get neutrophilia and bacterial disease, viral diseases first. Pertussis or whooping cough is something that you see. 35-year male with splenomegaly, leukocytosis, and you have the entire spectrum of myeloid cells. You do it, a CML you can pick up. And currently, peripheral smear is the only investigation that you do. And you need not do a bone marrow in most of the situations. A good peripheral smear followed by karyotyping and your BCR-ABL is good enough to diagnose CML. But it is useful in follow-up for accelerated phases, basophilia, and also all remission need to check out on the peripheral blood. It's important. When we look at blasts, this is probably the only thing that I'm concerned now of picking up in a blast, the aurora. Okay, of course, there's another type of acute leukemia which you must diagnose on the peripheral smear. I'll just come to that. So whenever the M0 to M7 classification is there, it's always a question asked for the undergraduates. Though we have gone beyond M7 and M0 and M5 classification, but it still forms a pet question for people in our country with the way of teaching that we do. At a postgraduate level, yes, it's important to identify what lineage it is on morphology, but you need to do immunophenotyping and flow for confirmation. This was an emergency smear that came 15-year-old girl bleeding all over with pancytopenia, and this is what you saw. What's your thought? Atypical promyelocytes. This is again like your TTP, another diagnosis that you must not err and be as quick as you can in reporting that I am looking at promyelocytes, because it is an entirely now good treatment is there, ATRA is there, 90% cure is there. So promyelocytic leukemia is another condition which you must be able to identify. And you have the classical form with Faggot cells, Sudan back or myeloperoxidase done highlights all that, or you could have the hypogranular form. But whatever it is, it permits us very rapid provisional diagnosis, looking at the peripheral smear, and then you follow it up with your investigations. Blasts of ALL can also be picked up, and if you have provision for PAS, not very routinely done, but yes, it gives you the confidence that I'm dealing with an ALL. But yes, for all other acute leukemias, you need to do the linear assessment properly. Another acute leukemia. Any thoughts? Cytoplasm calculation. This is what you see in L3, the old L3 or bucket leukemia currently, the older L3. And mind you, ALL, the acute lymphoblastic leukemia cells also show vacuolations, may show. The glycogen may get not stained and become vacuolated, but this deeply blue cytoplasm with punched out vacuoles, nuclear vacuolation is what was typically seen in bucket. And this is again another condition which you can do in emergency reporting. More of a curiosity, we used to have these hand mirror cell leukemias in ALL. Okay, this again kind of diagnostic in the situation. Elderly man who's got skin lesions. He's got an erythroderma, and this is the blood smear that has come to you. Okay, typically, cerebriform Sézary syndrome, TALL, AITL, all of them, the ATL, the leukemia lymphoma of adulthood, all of them have this kind of a convoluted or a cerebriform. So this would be a good diagnosis to start with. The cerebroid nature of Sézary syndrome or TALLs, etc., would be a good point. Now we move on to a more mature appearing. These are generally elderly man with generalized lymphadenopathy. This is where your chronic lymphocytic leukemia comes in, and you see that kind of soccer ball appearance, irregular, not very many prominent nucleolus. This was 2 years later in the same patient. That's the CLL, the soccer ball, and here and there you now start finding cells which are larger, prominent nucleolus, and this was kind of earlier CLL when you had 10% of lymphocytes. Now the entity of lymphocytic leukemia is kind of going away, excepting when you have a progression of CLL to PLL. Okay, so this is again morphologically you're able to say. Even smudging, which are basically degenerated cells. Once upon a time it was said that it could have a prognostic significance. There were papers published that percentage of smudge cells can predict survival, but this was some time back saying that patients with less smudge cells had a better prognosis. Anyway, smudging is an important corroborating finding in CLL. Now, can you tell me what is this patient having? I'd shown a similar slide some time back. What would be your diagnosis on this slide? This is giving you a complication of a disease, a variety of the CLL with autoimmune hemolytic anemia. This patient's hemoglobin would be very low, marrow may not be so infiltrated, cones would be positive. So again, looking at the peripheral smear, you get a diagnostic workup. All these CLPD cells may look alike, so keep that in mind. This is what you see in SLVL, splenic lymphoma with Willis, bipolar cells. This is what you see in hairy cell leukemia. This is what you see in follicular lymphoma, the cleaving of the cell. So there are some morphological clues which will help you in diagnosing your cases. When you set up a CLPD panel, clinical history and the morphology does help you in identifying what type of disease it is. This is something that we keep showing, the typical cup-shaped nucleolus or whatever is seen in NP1 mutation. So morphology up to molecular can be identified. Heavily made with cytopenia. Now let us see macrocytic index, and you see a blast. You look around, there are not too many blasts, but you also see some pathognomonic cells. What are these? Neutrophils, which are very small, spectacle shaped. Yeah. Pseudo-Belgaroue. Pseudo-Belgaroue is a feature of myelodysplasia. Hypogranularity, hypergranularity, abnormal lobes, all these features of myelodysplasia can be identified on your peripheral smear. Especially, this is very, very important finding. All your results, I don't know if you've seen this blood. Apparently from one patient, this neutrophils from A to Z. Oh, when you look at the WBCs, you check the counts. That's the first thing that you do. Check the differential. I rely on the automated differential as much as possible currently. You can pick up the top reactive changes. You can pick up blasts, lymphoma spills, and this myelophosis. All this helps you out in identifying the WBCs. Right. The two corpuscles will have been brain. Both had a heart-shaped structure. Just platelets. This is one thing. Thankfully, the reference range is normal. There's no difference in the platelet count between gender, age, race, whatever. It's all 150 to 400. Looking at the peripheral smear for platelets, it's a rough guidance. It gives you an estimate. You do not make an absolute count. It's a valuable check on the counter values. That's why we look at it. One platelet per oil is roughly equal to 10,000. Approximately 12 to 14 platelets in a high power field. If you see clumps, it's often difficult to give an accurate count. That makes it adequate. So we have this first case, a routine PS 35-year-old man. I don't see platelets at all in low power. I don't see it in high power. What I have is I have not looked at the tail. Okay, most of the platelets, as we discussed right in the beginning, get caught up in the tail. So if you have a which is a tailing, look for platelets in the low power itself, you'll find out. This was a child with an emergency sample that came middle of the night saying that, oh, you diagnosed trypanosomiasis, Chagas disease or something. My resident called up. Activated platelets. Platelet can have varying morphology, especially if allowed to store. You collect a sample, 5 hours or 6 hours later, you make the smear. Platelets can become very, very irritable. So much so that they just look like trypanosome things. So this was how it was. This is actual trypanosome, how it looks in the smear. So these are activated platelets. Also, if your staining is understained, you might miss out on platelets. So keep that in mind. You might miss out on platelets when your staining is not good. So this was a 14-year female with menorrhagia. Platelet was, it's an EDTA sample. Platelet was 175, and this is what you find. Patient has menorrhagia, the intensity is there somewhat, and you find scattered platelets because it's an EDTA. What do you do? When you're suspecting or the clinician tell us whether this patient has a bleeding tendency, it's always good to make a direct fingerprint smear. Either a fingerprint smear or when you're collecting the blood, instead of putting it into the EDTA vial, make a smear. So a direct fingerprint smear, if it tells you that they are still scattered, yes, then you look for platelet function disorder. If on a direct smear you find good clustering, good clump, check out with the gynecologist. The menorrhagia could be nothing to do with your platelet function. So always look for a direct smear. So you get various morphological, large platelets, small platelets, and your counter values often give you good results. So spurious low counts can happen in partial clotting of blood. Careful, check the sample and prolong storage. Be careful when you have a fibrin, your counts are haywire. This was a 30-year-old lady who had menorrhagia, and repeated platelet counts were in the lower range. Lower range means low. Gynae checkup was normal. She had a vaginal delivery, extraction of Aries tooth, everything was uneventful, but her lab platelet count was 38,000. She had been investigated extensively for functional platelet disorder, but a smear unfortunately revealed this. So this is what is called EDTA-induced pseudothrombocytopenia. So patients go around in circle, but if a smear is made and carefully look, and that is it. So you know about the situation EDTA-induced, not very common. It's less than 1% of cases show, and it's because of this cryptic antigen on 2B3A by EDTA that is there. EDTA-induced thrombocytopenia is often seen in patients with connective tissue disorder. So that's one little clue that you can have, and you know that you troubleshoot it by citrated count or do a manual count, various conditions. Basically, just a manual count is good enough to obviate this situation. A 10-year-old boy with bleeding gums and prolonged bleeding after trauma since early childhood, child of a consanguineous marriage. So you know you're dealing with possibly a functional disorder of platelets. No? History-wise, it's prolonged since early childhood, but your platelet count is 7,000. It's very, very low for a inherited platelet disorder. So what's wrong? Look at the smear and you find these large platelets. So be careful about spurious low platelet count. So whenever you have a platelet count which is subnormal or excessive, please have a look at the smear. So this was the case of Bernard Solier, whose platelet count, otherwise look at the size of the platelets. Because otherwise, fairly low, normal, about 80,000 or so, but the machine gave a very, very, very low value. Of course, what is this disease? Again, peripheral smear, giant platelet, and what is this? Tall body, you can get a diagnosis of malaria anomaly. This was the case, again, we got 22-year-old antenatal platelet was 70,000. And this was a very well-made smear. But if you look, first we missed the platelets totally. But if you look on careful look, this is what we saw. All the platelets were very big and agranular. Didn't have the eosinophilic color. The RBCs were beautifully stained. So this is what we came up with the diagnosis of a great platelet syndrome. Okay, so that is how looking at the platelets also helps. 45-year-old lady, otherwise asymptomatic, admitted for cholecystectomy. Platelet count was 95,000. And based on this, the surgery was deferred and a PS was asked for. And this is what the PS showed. What are the RBCs? Right, and giant platelets. Any thoughts? Any thoughts? Patient was otherwise kind of asymptomatic. Giant platelets. She was a Bengali lady, and this is an entity called Harris syndrome. Mega thrombocytopenia. It's incidental and asymptomatic, but with presence of spermatocyte. Any other disease that comes to mind? A fairly slightly more complicated disease. With coronary or vascular lesions. There's an entity called phytosterolemia or steatosterolemia, which is basically increased slightly. The body has a tendency to increase fat absorption. So there is increase in hyperlipidemia and stomatocytosis with giant platelets. It's a rare condition. So giant platelets can be seen in a wide variety of conditions. So falsely lowered counts are seen with agglutination or extremely large platelets. No, at times it happens when you have an ITP on recovery, post chemotherapy recovery. The platelets are adequate in number in the peripheral blood, but the count is coming as low because they're big. Of course, current platelet counts by the optical not impedance has solved this problem to a greater extent because now the platelets are better identified on the counted on the counters. A 36-year male with generalized lymphatic blast is a case of acute lymphoblastic leukemia and presented with TLC of 78,000, platelet of 120. And this was a classical ALL, but however, within a day, the TLC dropped and the platelets rose. We first checked whether it was actually some other patient samples were sent or not, the same patient. Within 24 hours, this is what happened. And in the smear, we saw these. The blast had fragmented. This was a case of spontaneous tumor lysis syndrome, and the blast had fragmented, and therefore you got falsely elevated platelet counts. So all these are blast fragments, not really platelets. Similarly, such false high platelet counts can be seen in DIC because the schistocytes can be counted falsely. Again, with newer advances, most of the cell counters are able to pick it up better. Schistocytes can be a cause for pseudothrombocytosis or increase in the. This was a newborn baby. Platelet count was 18 lakhs. This was our case. These are two from the neck. Platelets were 18 lakhs on the counter, but this is what we saw. What happened is, that particular day, not just this sample, subsequently 3-4 samples showed thrombocytosis. Very high platelet count, and all of them had the same morphology. What happened was, the samples, the EDTA samples that were collected, were kept on top of a hot air oven before they were transferred to the lab. So this is thermal effect. Heat-induced breakage of RBCs and cells leading to a false pseudothrombocytosis. This is also seen in a condition called hereditary pyropoikilocytosis. Okay. So false high counts are rarer, but can be seen in a wide variety of conditions, including again things like hyperlipidemia, cryoglobulinemia, etc. So platelets, look at the smear when platelet counts come low. You're confirming thrombocytopenia, and you can find out the underlying cause of thrombocytopenia, looking at blast besides the IC. When the platelet counts come high, confirm, and you can look at the underlying cause also. Giant platelets, basophils, you know what it is. Look at the smear when platelet counts come normal, but clinically is discordant. They're saying that the patient is bleeding, but my platelet count is normal. Or they're saying that the patient, so such situations also look at the peripheral smear. Morphology and function helps. So finally, the peripheral smear used for catching the bugs. Malaria, of late, we don't get too many cases of peripheral smear for malaria diagnosis because either they are empirically treated or you have other means of diagnosing. So our rate of picking up malaria has come down on the peripheral smear. But at times, you pick up, not the straightforward case of fever. This was a newborn baby with jaundice and we identified by that. Right, so this was one. Patient came with a feature of dengue, NS1 positive also. Platelets for 40,000 and we picked up. What is the rings? Yeah. This was the case where there was mixed malaria, both vivax and falciparum rings were there. Okay, so unexpectedly, we are able to pick up malaria nowadays. The straightforward cases of malaria are probably going away. Hopefully, we are on a decline with malaria. There are certain morphological clues to the peripheral blood in malaria cases, especially the chronic ones, and these are the hemozoic pigment in the monocytes. What is this? Which parasite?
Babesiosis.
Maltese cross appearance or babesiosis, and this one? Something like borreliosis. And these? Microfilaria. Okay, again, though Pondicherry, where we are, was once upon a time endemic of filariasis, we are not picking up too many cases of microfilaria anymore. What about this? Fungi. Okay, they may be a clue. These are not parasites, these are not anything, they're just these forms of contaminated. Maybe your stain had fungus growing in it. Or at times, even the tube or the vial, when we used to have EDTA vials, the vials used to grow a lot of fungi, and this is a contaminant. What is this?
Antisepsis.
Threads, cotton swabs. No microfilaria is this long. What is stippled RBCs? They are not vivax, vivax prophyzoid. That's a cabo ring. So be careful about when you're reporting out on parasites. So a peripheral blood is useful. Diagnosis, differential diagnosis, again, possible diagnosis, all of this. beware of your artifacts, beware of your counter values and comparison, right? So that's where we will wind up. Just a little for all of you. 2 weeks down the road, we are having this hands-on workshop on morphology at Mahatma College. Some slots are still open, 28th, 29th March. All these cases and much more will be available for you to view and discuss with the faculty there. And we've added some colors. Happy Holi, all of you. Thank you.
Thank you so much, sir, for this excellent talk, and you at least led me through a long memory lane. And I was so happy that each and everything you were trying to highlight some findings which we see very often, some findings which we look for, some findings we suddenly it just comes to us. It was wonderful, sir.
Thank you. Thank you so much. Okay,
so
Ashish,
I am-
one second. Ashish, sorry if I went too fast. He's been repeatedly telling me, could you just switch on the video and let me know who you are? Next time, if I get a chance, I'll try and go slow. Periodically.
Maybe we can attend your workshop, sir.
Thank you. Yeah, why don't you come down to the workshop? That's a good idea. Rita, come over. We'll be as slow. 1.5 days are there for you to help us out. Right.
Hi, Mukul, anything you want to say?
Yes, Dr. Mukul, sir.
Sir, I'm Urvin. So thank you for this excellent, comprehensive, and very interactive session from your side. You've let your decades of experience pour into the session. So just to summarize that, your approach to a peripheral should be a systematic one, and so should be your report now. So
Yes.
your report should contain all the elements, whatever your findings are. It's important to be quick with your reports. Your quickness will be important, especially for some diseases where you are going to help with starting of treatment immediately. So be it TB, be it cholestatic leukemia, and many others, including many parasitic infections. And obviously, your peripheral smear will be guiding to the host of investigation which your clinical counterpart is looking forward to. Again, last I like to say that communication is your key.
Yes.
So when you are in doubt, just WhatsApp call your clinical colleague. What are you looking at? What do you want to specifically, if you want to look for anything specific, or what are your differential in such a scenario? This communication is key, and this is very helpful, and this can really guide the care of the patient and guide into quick care for the patient. Thank you, sir. Thank you.
Thank you. Mukul, on the same note, as a pathologist, the initial information from the clinical side is also very, very important. If you look at it, majority of the CBCs come without any history. Only when we pick up some abnormality or communication. So that is two ways. All of you must communicate with your clinical colleagues at any point of time, even before receiving the sample. Get to know the history if it is not available, and while you are reporting, while you are seeing, it's always very, very helpful. You get information which you need to be able to diagnose. Yes. Thank you.
Thank you.
Thank you,
Gujarat,
Basu.
sir, can I make 2
Yeah, sure.
points?
Yeah,
Two
Sure,
comments,
please.
So 2 interesting experiences which I had when I was working and I was teaching. So one was one day I had our transfusion person, blood bank officer, come to me and she said, "I need your help. I have a problem. I have a transfusion reaction which has been reported and the sample sent back to me. The patient underwent a surgery for pelvic tumor and was started on transfusion. And in the post-op room, she started having hematuria. So she had a catheter in situ and there was blood coming into the back. They said that this was mismatched blood which was provided by the blood bank, and a report and an inquiry went to it. So then she said, can you see a smear? I said, yeah, of course. So we made a smear from the remaining sample which they had sent back to the blood bank. So that the smear showed all RBCs were either microspherocytes or were cremated. So then I said, please give me the sample. So by the time in the post-op, they had stopped the transfusion, hydrated the patient, started on initial transfusion reaction management. So this was the second day. So I said, get me the sample from the patient now. So the current smear showed, of course, anemia, severe anemia, a lot of polychromatophiles, and I was not seeing any of those cremated or microspherocytic cells. So I told her my findings, and then she did her inquiry, and she went to the OT, everything. She questions every person who was involved in the surgery. And then she comes back on the third day and tells me that, madam, the surgical PG had put the bag in the incubator before transfusion. So that was the effect that we saw. Second instance was a child, 5-year-old. He came to the OPD with bleeding from the ear. So his HB was normal, and he was seen. He was taken history, and he was asked to come for a coagulation workup on the next day. So in the night, he calls the doctor and says that he started bleeding again profusely, and his pillow is completely bloodstained. So he was called to the hospital back. So we didn't know what it was. So we couldn't do any investigations also immediately. So we took the previous day he had a CBC. The next day when he came, also he had a CBC. So we saw that the previous day, his CBC was normal. His platelets were like a little difficult to recognize. On the second day, they were just like rings. The platelets, they were completely hypogranular. So we went on in this case to make a diagnosis of acquired platelet dysfunction with eosinophilia. So eosinophilia was there. So we didn't go on even to do a PF platelet function study. But that's just because of the peripheral smear that we would have otherwise missed.
Yeah.
And maybe one addition, if I can make, we have seen a lot of stomatocytosis coming in acute ethanol intoxication. So acute,
yes.
Yeah. So we maybe in Kerala we see a lot of them. So
No,
that is
there
one,
is nothing disparate about alcohol intoxication.
Hi, Bhushan.
Yeah,
Thank you so much.
We get that.
Bhushan, you're unmuted, but we can't hear you.
Dr. Bhushan, yeah.
We can't hear you. Either your loudspeaker volume is low. We can't hear you, Bhushan. You can log out and join again. Maybe we can.
Am I audible?
Yes, now.
Okay. Just wanted to thank sir for such a lovely talk and touching upon very important issues. And I'm glad that you very nicely brought out the pre-analytical variables, especially that case where you mentioned how pyropoikilocytosis was misjudged just because the sample wasn't kept properly and it was kept in the wrong place. So that's a very important take-home message that we should go that extra mile to first rule out these variables before we start writing out them as a diagnostic finding. So I just had one small case to discuss and or rather share with everyone. We had one case of a very major severe head injury, and the patient was very badly off, and we got the peripheral smear of that slide. and the smear wasn't made too well. But I've always had this habit of seeing the smear in entirety, and especially when the smear is bad, then I always look at the edges and at the periphery just to see the better preserved cells and see if it can arrive somewhere. And there, in a case of head injury and all, I was searching around. There were very few RBCs which were morphologically identifiable, and in some of them, I could see presence of malarial parasite, the falciparum ring. And that is what made me, put two and two together, and I realized that this patient was a case of severe malaria, and he was not doing constitutionally well, and he was moving around on a two-wheeler, and that's where he had his accident, and he landed up with this head injury. So had I not picked up this finding, a head injury peripheral smear would have just gone like a routine peripheral smear, and if it wasn't made too well, probably it would have been missed, and we would have probably saved the patient from head injury, but lost him to falciparum malaria. So that's when the treatment was started, and we could salvage that patient. So just I wanted to add that we should not just throw away the smears which aren't made well, especially if we don't have an access to a repeat sample, because if the smear is not made well, it's not the patient's fault, it is our fault, one of us. So we should spend that extra minute to see if we are not missing out on something really relevant. This is what I wanted to add. Thank you.
Thank you,
I
sir.
have
Thank you, sir.
hello.
Yeah, Urvi.
No, sir.
Think all well. I think, Basu, any final comments from your side?
No, nothing. That's quite late.
Thank you very much. Then Geeta and
Please for dinner and then enjoy tomorrow.
yeah, I mean, students, and especially two students arrived, I think, to your talk. Sheetal and
Yeah,
Saurabh.
that,
The rest, I know I couldn't see them. But Basu, as always, I enjoyed your talk. Thank you very much for, as Mukul said, wealth of experience you put in these 1.5 hours, almost now 1 hour 50 minutes. And Mukul, thank you always for joining, and despite being a busy hematologist, I think you're always there to ready to teach and, and share the final points. Thank you very much, dear.
Thank you, sir. Thank you for coming.
Thank you, everybody.